Hi there, welcome to my YouTube channel and our ongoing discussion about psychiatric disorders. Today we're going to talk about major depressive disorder. No surprise, most people are familiar with depression, as it's called colloquially, but I wanted to actually kind of outline how psychiatrists diagnose major depressive disorder. Now, I've oftentimes said that depression, as many people call it, is not just glum face. It's actually a syndrome. And it's associated with many facets that patients may not see at the outset. Now, the way it's defined, at least from the DSM's perspective, is of a persistently depressed mood for at least 2 weeks, kind of most of the day, every day. In practice, I had to ask more probing questions to figure out what the mood is like. And there will be times in that 2 weeks when people might find something that cheers them up, that distracts them. But the underlying tone, the background tone, the side of themselves that they don't show to others, that's what I ask about, will typically be kind of persistently low, and not much will lift it. And there are associated symptoms that we need to look for. In the DSM, we talk about kind of diagnosing 5 out of 9 potential criteria, but essentially what I'm looking for with depression is a persistently low mood in association with kind of inability to experience pleasure, sometimes associated anxiety, with a ruminative kind of chewing and stewing quality that we've talked about in the anxiety disorders before, and classically, some form of disturbance of sleep, appetite, and energy. And when I'm asking about sleep, that's where I really zero in on what's going on, because there will inevitably be sleep disturbance. Either it's hard to fall asleep, hard to stay asleep, sometimes I wake early in the mornings, and depending on the answer, they may fall into a subcategory of depression, such as an anxious depressive disorder, or a melancholic depressive disorder. And these are the subtypes, but certainly sleep will be disturbed. What's common to all of the subtypes is that sleep is classically unrefreshing. You feel like you haven't had a good night's sleep, no matter how many hours you've slept. Some people will want to sleep more, some so-called hypersomnia. But more classically, more obviously, people will have insomnia, and it's characterized mainly by anxiety or kind of negativity in their ruminative, chewing and stewing kind of thinking quality at that time. And what has been famously described as Beck's cognitive triad from Aaron Beck, who studied the depressive disorders in great detail. He'll talk about basically how the mind tends to think negatively about the past, present, and the future. I very much subscribe to that model because I think that negativity is pervasive. In other words, it kind of influences the way they think about everything. And you can tell that their mind, when they think about the past, is selective for negative things. Their mind, when they're thinking about the present, is selective for negative things. And certainly when their mind is thinking about the future, is very much honed in on negative outcomes. So that, again, gives me a very strong flavor. Their thinking will be very negativistic and anxious, oftentimes, because the two are kind of very much related. We talked about anxiety and depression being brother and sister. Many a time, anxiety can be a very presenting feature of depression. But there will be sleep disturbance, of course, associated with both anxiety and depression. Appetite is classically affected, will classically lose weight, they don't feel like eating, they'll skip meals. In some what we call atypical depressions, they may eat more to cope and may gain weight. Those are the so-called atypical depressions. There's a phenomenon described in the DSM called leaden paralysis, where they feel heavy, their arms and legs in particular feel very heavy. I haven't found in my practice that to be as reliable a criterion for describing atypical depressions as the weight gain and overeating and oversleeping, hypersomnia. So again, these criteria are listed in the DSM. I don't think all of them are equally common in different depressions, but you're getting the sense that basically sleep, appetite, mood, and energy are particularly affected. They'll get easily tired. They don't feel like doing things. They're not motivated. They certainly don't enjoy most of the time, or a lot of the time, what they're doing. And there's a bleakness about them. They will be, in their behaviors, much more socially withdrawn, not really very reactive to things that other people might find funny or entertaining. They'll just kind of like be flat in their affect, their so-called objectively observed mood. When I see them in clinic or sometimes in the hospital, when I'm seeing depression, their eye contact will be poor, their range of facial expressions will be very limited or restricted, the rate and tone of voice will be much lower, simply the amount they speak will be less. You kind of get in the picture that basically they've kind of gone into their shell, a cocoon of sorts. They're just living in a much smaller world and they're in distress, and it shows. So those are the kind of cardinal manifestations of a major depressive disorder. We don't call it depression. The public calls it depression. We call it major depressive disorder, and there are different subtypes. There's melancholic, where you have classically more weight loss. There's early morning awakening. Melancholic depressions are typically more severe. They may end up being hospitalized because of the amount of weight loss, because of what we call psychomotor retardation. They just simply slowed up in their movements or their interactions, that they're practically not moving. And that can cause what we call a catatonia. Sometimes they can be literally frozen. And those type of depressions are very severe, require hospitalizations, and respond to treatments such as antidepressants in combination with antipsychotics. They may even require ECT if someone's literally not eating or drinking. So those are the much more severe end, the more severe subtype, which is the melancholic depressions, where they're just flat all day and literally not moving or moving very little, eating very little, profound weight loss, really worrisome. More commonly we see in the inpatients and outpatients a more agitated or anxious depression, where there's a kind of like antsiness about them. They're very, very worried and preoccupied. There's a very strong anxious presentation. They're oftentimes what we call rejection sensitive. They're very, very sensitive, easily moved to tears. Of course, I'll ask crying spells, how often would you typically have them? But they'll often describe they just move to tears more easily by watching a movie, for example. The movie moment that is tender, but they'll be gushing in tears as a consequence. So you can tell they're very fragile. So anxious depressions, you can sense the sense of fragility in the patient. The atypical depressions are rarer, may occur more likely in younger folks or maybe even older folks, and require medications such as the MAOIs, monoamine oxidase inhibitors, which are much more rarely used by psychiatrists now because there's such a restriction on the diet that can be prescribed for them, because they'll have interactions that can lead to upticks in their blood pressure, which can be dangerous and potentially fatal. So they're often not combined with other medications such as the SSRI, or they need a washout period whereby other medications are going to be out of the system for at least 2 weeks before these medications are started. So there are different subtypes of depression. Sometimes what we call a seasonal aspect, whereby typically depressions are worse in the winter months, where the days are much shorter, much more bleak in those times, and in the summer somehow with more activity they'll be much more active, and light therapy has been recommended as a treatment for that particular subtype of major depressive disorder. Now, depression in many folks is recurrent. Some people will have one episode, but in my experience, if you've had one depression, you're at risk, and this is borne out by research, you're at risk for another depression. So oftentimes we'll describe either depression as a single episode or recurrent, and we'll describe the subtype, and then we'll describe the severity, mild, moderate, severe, depending on what we're seeing and how many criteria are met, and the degree of dysfunction that we're seeing. Are they unable to simply get up and brush their teeth, get out of bed, eat, talk, interact? How severe is it? Are they able to go to work? Are they able to focus? Are they able to concentrate? Is that impaired? Are they able to power through their day? Oftentimes people will not present for depression, you can imagine, because they're withdrawn, they don't see the point of things, they're too negative in their appraisal of medications, and they see all the doom and gloom in the medication stories that they're reading on the internet or talking to other people. They're just not going to want to be treated. That's not true of all patients. Anxious patients want to treat because anxiety is very much more disturbing, and that will bring them to the doctor's office earlier. Treatments for depression, of course, are the SSRIs, which are the mainstay. They've pretty much taken over from the tricyclic antidepressants, like the old medications like amitriptyline, imipramine, now Prozac, Paxil, Zoloft, Lexapro, very much the mainstay medications for depression. There's one particular medication for depression called Wellbutrin. Now that inhibits the reuptake of dopamine. Dopamine is what I oftentimes describe as the zest chemical in the brain, the zest neurotransmitter. It gives you increased energy. In fact, dopamine goes up when people have sex, when they've had food, when they're enjoying themselves. And so the melancholic depressions are very much the opposite of that, where there's very low dopamine transmission. And something like a Wellbutrin, in different formulations, SR, XL, XL, depending on how long you want it in the system, can very much improve those. And I've actually used it very successfully, extremely successfully actually, when I've augmented an SSRI, which is whereby they partially responded. They responded up to a point and somehow they plateaued. And that's when I add in Wellbutrin for low energy, anhedonia, the sexual drive is still poor. They'll blame the medications like the SSRIs for poor sexual drive, and that's a chicken and egg thing with depression, of course. But I'll add in Wellbutrin as an antidote both for that and to give more oomph, as I call it, energy, zest, initiative. And I've had a lot of success when that is added on, because we know that in terms of the biology of the major depressive disorders, that the amines, the serotonin, noradrenaline, dopamine are all reduced. And that's an old theory, but guess what? That's from the 1950s. But we do know that they do work because they raise typically neurotransmission of the biological amines in the system, dopamine, noradrenaline, norepinephrine, and serotonin. For treatment-resistant depressions, and how do we find treatment-resistant? Is when you've had an adequate trial, that means an adequate dose of the right medication for long enough, 6 to 8 weeks. You've had more than one trial of those, you've had 2, and they've not responded or only partially responded. We may have to augment with additional medications, such as mood stabilizing agents, lithium, gabapentin, lamictal, Depakote. And we've had successes with those medications when they're added on, sometimes within a few weeks or even days of adding those to an existing antidepressant that's maxed out. Other medications include thyroid hormones, N-acetylcysteine. Again, I don't want to get too esoteric about these, but there's a strategy for treating depression that is very much outlined in practice guidelines and has been researched in controlled trials, that there's a stepwise approach that really should be used. I've oftentimes seen, mix and match where people haven't been properly maxed out. I've talked about this before. They haven't been adequately added on, augmented, and kind of written things off, because that's their experience. But if we're systematic about it and we stay the course, and we max things out, and we augment at the next stage, you do see subtle improvements in certain what we call target symptoms. So some symptoms may not be better, but others may improve with augmentation. So it's a very much an iterative process, and you want to involve the patient in there to give you the nuances of what's going on. So that is a real kind of summary of what is a huge topic with a range of treatments, and I hope that's helpful. And as always, I want to thank you for your support. I look forward to seeing you in the next video, and stay healthy.